Skin Merkel cell carcinoma is a small round blue cell tumor theorized to come from the mechanoreceptors of Meissner's corpuscles and associated with polyoma virus infection. Workup history, H&P, history of sun exposure, history of immunosuppression, do a comprehensive skin and nodal exam. A core biopsy is required. Get a PET CT, CT chest, abdomen, pelvis, and MRI brain if a CT is unavailable. AJCC 8th edition staging. T1 tumors are less than 2 centimeters. T2 is 2.1 to 5 centimeters, not 4 centimeters like other skin cancers. T3 is greater than 5.1, or essentially greater than 5, not including 5. T4 is invasion of the fascia, muscle, cartilage, or bone. N1 is a regionally positive node. N2 are in-transit mets without nodal mets. N3 is in-transit mets and nodal mets. The management for Merkel cell is a wide local excision and a sentinel node biopsy followed by adjuvant radiation. The excision requires 1 to 2 centimeter margins, which are much larger than the half centimeter margins for squamous cell or basal cells. Sentinel node biopsy, if it's negative, you can observe the nodal basin. If it is positive or there's clinical evidence of involved nodes, then you do nodal dissection or radiation to the nodal basin. A nodal dissection is preferred. Radiation details, you perform radiation for all patients. You can consider observation for small Merkel cell tumors less than 1 centimeter with widely negative margins without evidence of LVSI and in immunocompetent patients. You start radiation within a few weeks of surgery. For the primary site, you use bolus. You use wide margins of 4 to 5 centimeters in size, which are 3 times the surgical margin. For an R0 resection, you do 50 gray and 25 fractions at 2 gray a fraction. For an R1 or R2 resection, you do 60 gray and 30 fractions at 2 gray a fraction. If you have unresectable initial disease, you do definitive radiation, 60 to 66 gray at 2 gray a fraction. The nodal basin status postnodal dissection with only one node apparent and no ECE can be observed. The nodal basin status postnodal dissection with the multiple nodes or extracapsular extension gets treated 60 gray and 30 fractions. Status post-negative sentinel node biopsy, there's no need for radiation. If there's positive nodes but no dissection, the clinically positive nodes get 60 gray and 30 fractions. If you have a sentinel node biopsy positive but a clinically negative nodal basin, i.e. low burden of disease, you can do 56 gray and 28 fractions. If you have node negative but not sampled, sentinel node biopsy or dissection and at risk for subclinical spread, do 50 gray and 25 fractions. Evidence adjuvant chemo is usually not recommended. If there's disseminated disease, you consider nivolumab or ipilimumab. In the head and neck region, the risk of false negative sentinel node biopsy is higher, so you have a lower threshold for giving prophylactic radiation at 50 gray at 2 gray a fraction to the at-risk nodal basins. Evidence, there's a small underpowered randomized trial of surgery plus or minus radiation. There's decreased local recurrence from 17% to 0% with radiation. SEER data suggests perhaps better overall survival with radiation. Technique and planning, follow-up H&P skin exam every 6 months. A PET CT is clinically indicated. You can consider routine imaging in high-risk patients. Overall survival for T1 is 80%, T2 or node negative is 60%, and node positive is 30%. There's a risk of local recurrence, approximately 60% without RT, which goes down to 25% if node positive disease, and a 50% risk of disease regional recurrence. The next section is melanoma. Superficial spreading is the most common type of melanoma. There's also nodular melanoma, lentigo maligna, which is the best prognosis, acrolentiginous melanoma. You can call me Al, L-M-A-L, lentiginous maligna, acrolentiginous. Desmoplastic. Workup, do a complete skin exam and lymph node assessment. Excisional biopsy is preferred for any pigmented lesions, ideally with 1 to 3 millimeter margins. You need a CT chest, abdomen, pelvis, or PET CT for stage 3 to 4 disease, and an MRI brain if clinically indicated. Melanoma stains S100 and melon A positive. The path report needs to report the Breslow thickness, the number of mitoses, ulceration, margin status, microsatellitosis, perineural invasion, desmoplasia, and the Clark level. T staging, AJCC 8th edition, T1A is less than or equal to 0.8 millimeters thick without ulceration. A and B are with and without ulceration. T2A is less than or equal to 0.8 millimeters thick with ulceration or any melanoma that is 0.8 to 1 millimeter thick. T2 is anything above 1 millimeter to 2 millimeters thick. T3 is anything above 2 millimeters to 4 millimeters thick. T4 is greater than 4 millimeters thick. End stage is actually more complicated than what's listed here, but you can remember it as N1 is 1 node, N2 is 2 to 3 nodes, N3 is greater than 4 nodes. M stage, M1A is distant skin mets, subcutaneous tissue or lymph nodes. M1B is lung mets. M1C is mets to all non-CNS distant sites. M1D is CNS mets. Overall stage, stage 1 is T1 or T2A, N0. Stage 2 is T2B to T4B, N0. Stage 3 is any node positive. Stage 4 is M1. Stage 1 to 2 tumors, you perform wide local excision with lymph node evaluation, 1 centimeter margin for T1 and a 2 centimeter margin for T2. Sentinel node biopsy for clinically node negative and greater than 0.75 millimeters thickness. Observation versus lymph node dissection if just a few sentinel nodes are positive, and do a lymph node dissection for clinically node positive disease. Indications for radiation to the primary. Rarely is ever done. Definitive only in medically inoperable patients. You perform 64 gray and 2 gray diffraction. Adjuvantly, consider for close or positive margin. A re-resection is preferred. When re-resection is not feasible, typically for desmoplastic variant, or especially for desmoplastic variant, or extensive perineural invasion, do 60 gray at 2 gray diffraction. Indications for radiation to the nodes had to be stage 3 clinically and not just sentinel lymph node biopsy positive. A la TROG trial reduced 2-year local regional recurrence from 30 to 20%. No impact on survival. Increase in lymphedema 10 to 15 to 30% for cervical and axillary to groin. The indications for radiation are 1 positive parotid node, 2 positive cervical or axillary nodes, or 3 positive groin nodes. Alternatively, extracapsular extension or a lymph node greater than or equal to 3 centimeters in the cervical region or greater than or equal to 4 centimeters in the axillary inguinal region. The TROG regimen gives 48 gray and 20 fractions at 2.4 gray a fraction adjuvantly, 30 gray and 5 fractions at 6 gray a fraction given twice weekly for 2.5 weeks is the other option per the MD Anderson study. If unresectable disease, definitive to nodes is 50 gray, 2.5 gray a fraction. Stage 3 or 4 disease, adjuvant nivolumab, checkmate studies show progression-free survival benefit. Evidence here, TROG 0.201, Burmeister. Role of radiation to lymph nodes, 217 resected clinically lymph node positive melanoma, and no sentinel node biopsy was allowed with one of the following, either 1 positive parotid node or 2 positive cervical or axillary nodes or 3 positive groin nodes or extracapsular extension or a big, meaning greater than or equal to 3 centimeter cervical node or a big greater than or equal to 4 centimeter axillary groin node. Were randomized to 48 gray and 20 fractions versus observation. 6-year rate of lymph node relapse went from 36% down to 21%, which is statistically significant. There was no difference in overall survival, however, 35% for both radiation and observation. It is adjuvant radiation. Bottom line is adjuvant radiation for clinically detected lymph nodes in melanoma has a small improvement in lymph node relapse, but no confirmed benefit in relapse-free survival or overall survival. Second studies from MD Anderson, Ang, Red Journal, IJROBP, 1994. The topic here is radiation fractionation. This is 174 high-risk melanomas of the head and neck. Size of the lymph node was either greater than or equal to size of the tumor was greater than or equal to 1.5 millimeters or Clark's level greater than 4, N0. 2 palpable nodes or 3 nodal relapse. Phase 2 trial of 30 gray and 5 fractions biweekly. 95% of the dose to 95% of the volume. 5-year local regional control was 88%. 5-year overall survival was 47%. Bottom line, adjuvant radiation of 5 fractions led to favorable local regional control and low toxicity. The outcomes here, local control for stage 1 or 2 is 80 to 90%. Stage 3 with adjuvant radiation, overall survival is around 50%.